Okay, we're in the Zoom session. We're in the Zoom platform, and we have a very good signal. Okay, let's start our section 4 of this meeting. In this afternoon, we will focus on the treatment of HIV/AIDS. We will invite Professor Anton from the UK to give us an opening remark. First of all, I'd like to make a short introduction of Dr. Anton. He is a very famous physician, not only in Europe, but also all over the world. He is the master leader in the HIV/AIDS treatment. And his hospital is the biggest center for HIV/AIDS treatment in UK. And a lot of physicians in China once visited Anton's hospital and had a lot of benefit from their teaching. So Dr. Anton, please give us some remark for our meeting. Please, Dr. Anton. Okay, he is not online. It looks like he is not online. I think that he will catch up with us toward the end of section 4. Okay, let's invite the first speaker. That is myself. I don't need to introduce myself. Okay, thank you so much. I'm Dr. Zhang Fujie from Ditan Hospital of Capital Medical University of China. It is my great pleasure to give you a speech in this meeting. This meeting is sponsored by WHOCC, and actually I am the deputy director of that institution. So we cooperate with a lot of colleagues there. All right, in this afternoon, I will spend a little bit time in addressing the guideline of WHO, its evolution, and also the challenges in China in terms of HIV/AIDS treatment. Okay, I can control my slides, right? Yes. We're always talking about the treatment of HIV/AIDS. It is the second most important infectious disease all over the world. So if you have a look at the WHO guidelines, HIV/AIDS guideline is a kind of exception because this guideline is updated every 2 years. But in China, it looks that the update in China is not so frequent as WHO. So you can see that in 2016, EFV was still regarded as the first-line regimen. However, since 2018, DTG is deemed as first line and the second line regimen, the preferred first line and the second line. So you can see that the WHO guideline is updated so frequently, and this will become our focus in today's meeting. Well, you can see that this guideline includes prevention and treatment. For the interest of time, we have to focus on the treatment side. So have a look at this guideline. It started from prevention and then testing and also linked to care. That is, once a patient, once a client was diagnosed as HIV/AIDS, how can we move on to the treatment period? And also in our Ditan Hospital, we have, a portal in our hospital, which is named as the number 8 of Ditan Hospital. It is patient online portal. So you can see that these are the new things in the new guideline of WHO. So in terms of drugs, DTG with 2 NRTIs as the preferred first line and the second line ART treatment for adult, adolescent, and the children. So a 3-drug regimen, it is the recommended preferred first line and the second line regimen for adult, adolescent, and children. So still 3 drugs in the WHO guideline. And also WHO recommended, rapid initiation of our treatment. And China is very active in launching the treatment very rapidly after the diagnosis. However, in other words, or in other areas of the world, the initiation of the treatment may lag behind. And also, it is recommended to use the point of care testing. And in this morning, we also addressed the issue of a point of care POC testing, which is very important for pregnant women and also to prevent drug resistance from happening. And also the process of surveillance is also included in the new guideline. So on the timing of ART, according to the definition of WHO, rapid ART initiation is the initiation within 7 days after diagnosis. So here we'd like to show our tribute to our CDC colleagues. Thank you so much for acting so quickly so that we can start the treatment in 7 days. So 7 days time frame is not a problem for the big cities in China. And for example, in Yuan Hospital of Beijing, they did a very good job in launching the treatment quickly. And also, you can see that if the treatment can be started as early as possible, the outcome will be better. And in the guideline, it also states how to start the treatment if the patient has concomitant optimistic infection, for example, with a TB treatment or with a meningitis. The ART should be started as soon as possible within 2 weeks. So it also stresses the importance of starting the treatment, ART treatment.
Возможные предоставить и соответствующие. 仪器方面的限制，但是在我们中国的话呢，现在在检测方面的能力呢，要明显的要优于。
So you can see that we have a very strong capability of doing viral testing. And there is some challenge in China. For example, in the rural area of China, the resources are limited for viral load testing. So highly concentrated testing in the rural area may be a problem. And also the time to issue a report is pretty late. So these are the areas to be improved in China. So I'd like to talk about first-line ART recommendations. So in the preferred regimen, you can see DTG plus 2 NRTIs is the recommendation, including adult, adolescent, and infant and children. So what's the definition of infant? For example, at least 3 kilograms and older than 4 weeks. So this is the definition of children. So this is the definition approved by the FDA.
This is our current regimen provided by Chinese government. EFV plus 2 NRTIs, 600 milligram. It is well tolerated. Currently, the alternative regimen described by WHO is still the first-line therapy for many lower resources settings. Also, many patients are still on 600 milligram regimen, so we still need time to improve. Within the 4 weeks from birth, the RSV is still in use, but we need to transition to DVT within 4 weeks, because the first generation integrase strand had a lower barriers of resistance, so we need that transition to occur. Here shows the regimen recommended across 3 populations. Listed are preferred first-line and alternative first-line therapies. You would see there are protease inhibitors and ritonavir. It is not available yet in China in such setting. For new agents, there are new problems. Some are not that warranted. For example, the NDT in Africa, the use of NDT has been indicated with association of neural tube deformity. Through follow-up and observations, here are data throughout the years. We have found that its use of DTG has been safe for pregnant women with minimal risk of neural tube deformity. For infant and child, integrase strand transfer inhibitors have been recommended to replace the standard of care because globally we have used integrase inhibitors more oftenly. However, its use in adolescents and children warrants some careful considerations. For example, when we put a first-line therapy and a second-line together, you would find that this regimen is superior to the standard regimen, in particular when used as a first-line therapy. When used as a second-line therapy, it is not inferior to the standard regimen. Overall, and and here also shows recommendation for children. The criteria are 4 weeks from birth, and there are weight criteria, and there should be dose titering, and here shows a second-line therapy.
对于一些中国的话呢，治疗在大的城市当中，比如像地坛佑安，都可以取得98%以上的一线治疗的成功率。但
For
是实
example,
际
the
上的
success
话
for
呢，
first-line therapy could be
还有一部分病人是不能够耐受的。关于二线的治疗的话呢，过去的经典
the treatment. For second-line therapy, there are 2 NTRIs and 1 protease inhibitor. According to the WHO recommendation, it is still DTG plus 2 NRTIs. In particular, in the failed settings, for treatment failures, it has been defined from WHO as this. The failure criteria is still 1,000 copies per milliliter. I thought it would be upgraded, but not. The comment reads is between 50 to 1,000, and when it is above 1,000, that means treatment failure. I feel that it accounts for the reduced accessibility of viral load testing. Here shows the second-line ART. When you use the first-line therapy and it fails, then you switch to a second line of DTG and 2 NRTIs. If the first line has been DTG, then you would use the protease inhibitor as a second-line therapy. Here shows the preferred and alternative regimens for different age groups. All of these regimens are available in China, including the NRTIs and protease inhibitors. Indeed, the availability of these regimens in China has reached global standard. We always mention the guidelines for resource-limited countries. For example, the testing of viral load. Therefore, the access to viral load testing for drug resistance is limited. If we are not sure whether viral load is above 1,000 copies per milliliter, and how can we achieve transition? Based on this issue, there has been a trial designed that you can replace TDF with alternative regimen. Here are the results that I felt a little bit surprised initially. Firstly, DTG based second-line therapy compared with a DRP-based therapy, the efficacy are comparable. However, the graph in the middle surprised me. If we kept the TDF and compared with the groups substituting TDF with AZT, you expect similar results. Therefore, if you develop intolerance to TDF, I thought that the result would be inferior to ACT, but the trial concluded that they are similar and comparable. Third-line regimen is also described from the guideline. Firstly, there should be national programs for third-line ART. This morning, we mentioned the national guidelines and policies, and on the technical level, WHO mentioned that nations should describe their third-line therapy. It is an urgent issue because there are multi-drug resistance, so we need to address it with a third-line recommendation. If multi-drug resistance has been developed and you're running out of options, you can stick to the original regimen because the wild type is more virulent and the original strain is still sensitive towards the original regimen. The risk-benefit ratio favors the continuation of the original regimen. Among our colleagues, we have talked about a relevant concept. When a patient has reached viral and immunological success and free of toxicity, shall we transition the patient? The answer is yes. Therefore, the guideline spans a chapter to talk about the transition strategies. If the patient has been on a regimen that is suboptimal, though the patient has experienced successful control, you still need to transition the therapy to an optimal one. It is a well-accepted concept. Here shows the previous regimen and how can you realize the transition. For example, you can switch to ACT plus 3TC plus DTG. That means if you begin with a suboptimal regimen, then you should recommend a transition to an optimal one. However, considering the limited healthcare resources, we still hope that we can have more resources from the healthcare insurance to cover and support the transition. For example, for this current regimen, we recommend the transition towards ABC plus 3TC and DTG as long as the patient reached the weight criteria. I spent 3 pages of slides to talk about one concept. That means initially, if the patient has been on a suboptimal regimen by the WHO and global standard, then you need to move the patient to a transition of the preferred and optimal regimen based on various workups. That means the WHO has focused on the sustainability of the treatment and bring benefit to the individual level and to the population level. Here shows the viral load and how it triggers decisions. For example, when viral load has been above 50 but within 1,000 copies, then you need to follow up on the viral load. If it's consistently above 1,000, you need to switch to an appropriate regimen. The last part of the guideline involves prophylaxis and prevention. Previously, we talked about medication, and for prevention, we can also use medication. The first part of prevention is PrEP. We use TDF or FTC with 3TC, once daily dosing. Also, the 2021 update mentioned a vaginal ring of dapivirine for PrEP. The guideline also talked about kidney function monitoring and bone marrow monitoring when the patient has been on PrEP. The guideline also described the frequency and the type of workups available and should be done. Also, based on the risk to the kidney and bone density of TDF, we need to monitor patients on those regimens. The schedule of follow-up varies among individuals based on their age and characters.
So this is the final prevention. So you can see that this is the preferred regimen, DTG plus 3TC or FTC and TDF for 28 days. And also there are other alternative regimens, including ATV, DRV, LVP, Calitra, or IL. For children younger than 10 years old, the preferred regimen is AZT plus 3TC and DTG. I'm not sure how many minutes I still have. Maybe I still need 5 minutes in talking about the challenges of HIV treatment and the care in China. So we know that we have 3 drivers in the ART treatment, the free drug, the reimbursed drug, and also the self-paid drug. So these are the 3 drivers. So we almost have everything in China now. And in China, the mortality is significantly reduced. And Michelle also, expressed his gratitude to China, that China has gone through an evidence-based journey to reduce the mortality. So this is a very good model demonstration to all over the world. And also we should follow WHO and UNAIDS we should care their life quality. So there are a couple of challenges in China. First of all, just like Professor Han said, 30% are not diagnosed. And a lot of our patients are diagnosed in the late stage. We have a lot of our patients in the optimistic infection in the world. And also the virus is always in the ongoing mutation process. You can see that different ARV drugs will make some toxicity effect on different organs, but it is a very significant trend that the new drugs are much safer than the old generation of drugs. So my personal idea is to suppress the viral load to under the level of detection, which is a 50 copy. If the viral load is higher than 200 copy, there is also, a potential of a transmission, and there is a potential for mutation, and the long-term failure rate will be much higher than the patients with some total suppression of the viral load. Of course, we don't have the long-term outcome study, but we know that the LLV happens all over the world. In our hospital, Ditan Hospital, the transient LLV patients account for 70%, account for 7% of our patient cohort. And there is another issue of resistance. According to WHO, if drug resistance is higher than 10%, and then the EFE plus 2-NRTI is not recommended at all. So you can see that 12 countries out of 18 have more than 10% resistance to NNRTIs. And this is another study in 2019 by WHO. That is in 12 months. In 12 months, you can see the ratio of drug resistance is much higher across 12 months. So drug resistance is a big challenge, not only for China, but for all over the world. We should also talk about another issue, that is HIV carriers are supposed to have the same life expectancy. So that's why they will have concomitant conditions. They will have geriatric diseases as well, just like the healthy population. So that's why I like to emphasize that we should manage the concomitant disease apart from HIV/AIDS. For example, how to control their diabetes, hyperglycemia, hypertension, and hyperlipidemia, how to control these kind of conditions. In our outpatient clinic, we have one day with some, surgeon, general surgeon, and a pulmonologist, sitting in the outpatient clinic to look after the patients together. I think that if there is no hope of the true cure of the disease, we have to mind a lot of things. For example, drug adverse reactions, complications associated, not associated with AIDS, and drug resistance, and the late diagnosis. So if the disease, if the virus is not going to be completely killed by the drugs in the future, we should mind those kind of considerations. So DTG as the preferred first-line regimen among adults and adolescents in the low and middle-income countries. You can see that China is still in the orange part. We still have room for improvement for further, penetrating this country with the better drug. We still have room for the improvement to provide the better service for the patients in China. Thank you. This is all I'd like to address. Okay, I feel a little bit nervous. It looks that I'm always on the stage, always a step on and a step down. Okay. In spite of this, it is my great pleasure to introduce my colleagues, those experts who have made huge contribution to HIV/AIDS treatment in China.
孙教授的话呢，就是幼儿医院艾滋病门诊的主任，他呢在管理。
So the next speaker is Professor Sun Lijun. He is from Beijing Ditan Hospital of Capital Medical University, and he has made a huge contribution to HIV/AIDS treatment in China. I believe that his outpatient clinic is the top-notch in China, and also he has some background of gynecologist. So that's why I think that Professor Sun is very experienced in handling the HIV/AIDS in the pregnant women and for the neonatals. And his articles have been referred, by a lot of international guidelines. So let's invite Professor Sun Lijun to give us the next presentation. Thank you, Professor Zhang Fujie, for your introduction. I feel humble in front of such a warm introduction. So, dear colleagues, good afternoon. My name is Sun Lijun. I'm from Beijing Ditan Hospital of Capital Medical University. I'm from the Infectious Disease Department. So I will talk about antiviral treatment in pregnant women with HIV and neonatals. So this is my index of my presentation. Firstly, prevalence of women living with HIV. Second, antiviral therapy in pregnant women with HIV. And thirdly, neonatals. So we know that by July of 2020, there was a population of 20 million for women infected with HIV, and most of them actually are in the period of children-bearing potential. So you can see that about 50% of them are women, in particular for the sub-Sahara region. 60% of the HIV carriers are women, and including 18% of the adolescent women. So that means about 5,000 new infections among younger women, and compared with some adult. You can see that women tend to do better for those above 15 years old in terms of reaching the target of 95%. So you can see that for women with HIV, you can see that the diagnosis rate and the treatment rate, and also the viral suppress rate is much better than men. And for China, what's the situation? So the current status is that 95% of the HIV/AIDS is transmitted by sexual behaviors, and also we have higher and higher incidence in the children and in the elderly population, and the proportion is 3:1 for the patients diagnosed with HIV/AIDS. And the second part of my presentation, antiviral treatment in pregnant women with HIV. So for the family with one of the spouse with HIV/AIDS positive, they may have a strong wish to have baby as well. So this is the human's right. This is the right of the people living with HIV to have children. So we have done a good job in China. So for the women with some children-bearing potential, we provide free screening for the pregnancy. So you can see that when the people get married, they have the benefit of having free screening, and also when they get pregnant, they also have the benefit to receive free screening. And also we have to emphasize that the HIV positive the person of the family must be must be completely virally suppressed. And also for the men, they should do something like the foreskin resection, circumresection. For male positive male and negative women or female, it is pretty easy to be accepted by the medical institution. However, for the women positive women side, it may be pretty difficult to be accepted by the medical institution. And here you can see that if the viral load is lower than the 200, we can reduce the infection for the fetus and the neonatal, and also reduce the exposure to the healthcare professionals. So what's the time span? So ideally, the pregnant women should be viral load undetectable for at least 3 months continuously. Of course, if you don't have the good resource, you just have one test in 1 month. But ideally, you should have a negative report for continuously 3 months. You can see this is 052 at the partner study. They emphasize that the viral load lower than 400 or 200, the condomless sex will not transmit HIV/AIDS. And also there is another retrospective study. So you can see that some of them had a PrEP, some of them had a PEP. There was no report of HIV transmission. And also this is the report by WHO. If the infant is going to be fed by a breast up to 2 years, you can see that 5 to 10 babies would be infected during pregnancy, and 10 to 15 babies will be infected during labor delivery, and 5 to 20 babies will be infected during breastfeeding. So if you see this kind of situation, you have to understand that it's very important to suppress the viral load in the pregnant period. So if the women is diagnosed as HIV positive, we have to initiate ART as early as possible. And we also need to consider adverse events, DDIs and PKs, and also the teratogenicity, resistance, and comorbidities. And we have to suppress the viral load under the limit of detection. If not good, we should adjust the regimen as soon as possible.
If they are already on ART, then you can maintain the original regimen. If there are PD or PK changes, then you switch the regimen. For pregnant women, we always need to test the viral load. It's a part of the performance evaluation of healthcare organizations, because there are 2 viral load studies free of charge for pregnant women. Also, it's covered by healthcare insurance. Initially, there should be monthly viral load study, and before delivery, it should occur more frequently. Here are the 5 top guidelines frequently used. One from US CDC, one from WHO, one from IAS USA, one from EACS, and the last one is Chinese government. The preferred regimen has always been the NRTD plus TDF, and for the NVP is not that used frequently. And alternatively, you can use ATV, and in Europe, it's more conservative that TAF has been used for pregnancy above 14 weeks. The addition of protease inhibitor has been used in other countries. And for China and for LPV, it's been provided in certain locations. For example, in Beijing during the mid and later trimester, then they are able to receive 2 NRTIs and the DTG. This regimen has been the first line in the US as well. So across the board, you will see Europe has been more conservative, that DTG should be given only after the 8th week. Overall, China follows the US guideline more oftenly. Initially, after pregnancy, it's ADT and TAF. Specifically for EVG, it's common for adults. And when you think of transition, you need to monitor viral load because there are PK issue and the transmission through the placenta. This all affects the infection likelihood of the fetus. On the right side board, there are women of childbearing age who have not developed pregnancy yet. Then the regimen is also 2 NRTIs and an integrase inhibitor. And you can also individualize the regimen based on patient's needs. This data and regimen has been based on the DHHS guideline 2021. After the report of neural tube deformity issued in 2018, after 3 years, we have clarified that the risk is irrelevant to DTG. So DTG is routinely recommended for populations across the board. For the mode of delivery, initially, people thought that they should deliver the baby with a cesarean section. However, the latest guideline said it is not mandatory that they go through C-section. They can still go through vaginal delivery, and the patients would also have their second or the third child. So it is easier to manage their future potential for delivery when we use vaginal delivery. If you still, if an C-section, whether it's C-section or vaginal delivery, you need to plan it properly and have it as an elective manner to avoid emergency C-section. And you should involve a multidisciplinary team to manage patients. 12 countries in the world has put forward the aim of removing certain communicable diseases among pregnant women. In 2022, China would be the host for a global meeting on women well-being, and we will talk about eradicating several communicable diseases among women. They include infection of neonates with HIV. Currently, it's at 3.5, and we should keep it below 1%. And for syphilis, we are standing at 50 per 100,000, and Beijing should be a pilot zone in eradicating those infections during pregnancy and infant. I am quite nervous about these targets because we need to work very hard to eradicate those birth-related transmissions. If one positive infection is identified at birth, or you are not sure whether they are negative, then you count weights and you need to initiate the ART as soon as possible. This is managed by the obstetricians and communicable diseases services. Then you test for CD4 count, viral load, and epidemiological history. And it is always safe to regard them as infected or positive, and then provide therapy until we are sure with the workup results that they are negative. I've seen 2 cases where the baby had an infected status 7 days after birth, and the baby has already received breast milk. So for the 3rd trimester and also perinatal scenario, you should not wait. We should provide upfront therapy. For the issue of breastfeeding, initially, we avoid breastfeeding at all costs, and we recommend artificial feeding. However, the recommendation has changed. It is contraindicated for women with high viral load or women who are not on regular ART. If they demanded and insisted on breastfeeding, for example, in the remote and rural area, then the mother should be on ART and be compliant, because we need to reach the U equals U target. We are doing a study to see whether this is safe enough. If the baby is born in an emergency C-section scenario, then it is more difficult to control the breastfeeding issue. Also, we need to monitor the viral load of the neonates and the mother, even though they are on a medication, and we should monitor the liver and kidney function as well. I remember there are 2 cases. One of them had an anemia and stayed in the hospital for 1 month with liver function damage. Therefore, we need to monitor their liver and kidney function. The 3rd part is follow-up on prophylaxis or antiviral therapy for exposed neonates. So neonates are categorized by level of risk. For the low risk, then they use 4 weeks of ACT. In the past, it was 4 to 6 weeks, but currently we have simplified it into 4 weeks of ACT. The 2nd tier is a high risk. That means the mom has not been on regular ACT with a viral load above 50 copies per milliliter or acute or primary HIV. In such case, we need a 3-in-1 treatment regimen. It is ACT plus 3 TC. And we have all these regimens available. For example, the Kelatra. For the RAL is not available yet, but we may expect that in the future. If it's a newborn with HIV and confirmed with positive virological test, then we use 3 drugs, ACT plus 3 TC and NBP. In the future, when RAL is available, we can also use that when the child is more than 3 kg in weight and 4 weeks in birth age. Alternatively, we can use Kelatra. I noticed an interesting finding that the DTG is grinded and separated into 3 doses to use. And so in such case, the DTG is used as an RAL. This is an option when the child is above 3 kg in weight and 4 weeks in age. You can use the same method for several types of tablets. Some are worried about the PD profile. We talked about it among the experts. For example, in the Peking Union Hospital, the nurse have grinded the tablets quite often when administering it for infants. And for the MVP that you are quite familiar, it's weight-based. And then for the infants with higher level of exposure, then you tailor the dose according to the fetus age and birth age. For the group of particularly high risk with the RAL, and it's based on weight and age. If you are not sure, you can always refer to this tool. For the HIV positive neonates, we need to follow them, and there are follow-ups when we need to test them for antibodies and NAT. The guidelines mentions 18 weeks, and we know that around 90% of them can become negative after 12 months. And there are also, I saw cases when they turn negative until the 26 weeks. Therefore, we need to monitor the viral load, and you can spread the tests apart. If there are 2 successive negative results, then you can arrange BCG vaccination for the infants. And also, it's an issue whether you document that in the neonates health screening card. We have seen 2 cases when the mothers had the infection, but the infants overcome the infection. But the healthcare professionals document that in the neonate health card, which became a barrier for kindergarten and school enrollment. So it creates a lot of controversy and issue if it's not handled properly. So we need to keep an eye on the follow-up, and I wrote a paper about this. It was quoted by other studies as well. So I look forward to have more communication with you, whether online and offline. Thank you. Thank you, Professor Sun, for your passionate and wonderful presentation. I thought it was a scientific presentation, and it turned out to be a commitment declaration. I had a lot of admiration towards you. We always talk about women account for half the responsibilities of the society, and that proportion is even higher in our meeting because the next speaker is Professor Zhao Hongxin, who is also an excellent woman. She is an advisor for doctoral candidates, and I admire her most because she has done a lot of work in diagnostics of HIV of the Ditan Hospital.
I think that the ward led by Professor Zhao in treating the opportunistic treatment is a very, very good, high quality. So Professor Zhao will focus on the toxic side effects of ART and how to address them. So please welcome Professor Zhao with a big applause. Thank you so much, Professor Zhang, for your introduction. So in my presentation, I'd like to address the toxic side effects of ART. And you can see that from the WHO guideline, they always say that the DTG is so good. In this presentation, I will focus on the toxic side effects of drugs. So I will talk about the other side of the drug. So hopefully this will not make you upset. Okay, so there are 4 classes of toxic side effects. So you can see that the first group is NRTIs. They are the backbones. What are the NRTIs and what are the toxic side effects? The first is AZT. So the first is bone marrow suppression, including high lactic acid and also the lipid hypertrophy, and also the other side effects. So ABC is okay for pregnant women, and it's also an alternative for patients who are not suitable for TDF. However, it has some side effect of the allergy. And also for D4T, D4T has been faded out of the stage. And the third class of drug is TDF. TDF is widely used in the market. However, it has some renal problem and also the bone density impairment. So you can see that osteoporosis may be a side effect of DTF. And have a look at the new drug in the NRTIs, the class, which is a TAF. TAF side effect is 1/10 lower than the TDF. However, there is another downside, which is body weight gain of a TAF. So you can see that these are the drugs not in use, and ABC and the AZT will also be faded out of the market. And it looks that the 3TC, FTC, the TDF and the TAF is widely used in the market. And for NRTI, there are big 4 drugs in the market. The first is efavirenz, and you can see allergy and hepatitis. The second group is NVP. NVP is gradually faded out of the market. It may have liver toxicity and allergy. The third one is ripivirine. Ripivirine is a NNRTI, so it also has its side effects. For example, allergy and the neural and the mental side effects. Another problem is the EGFR reduction, just like DTG. It is a kind of inhibition of the secretion of creatine. So it's a kind of a pseudo increase. And you can see for DOR or doravirine, the side effects is not listed. So it looks that this drug may have lower toxicity profile. So the third group of drug is the PIs. So this is the first core drug, which is very important in the heart. So it has a lot of problem like the lipid disorder and the GI side effects. And also you can see that there is a problem of renal stoning, and you can see that even though in the guidelines, the PIs is kind of alternative, not the preferred recommendation. So have a look at the newer generation of drugs, which is Incidence. So you can see that how about the toxic side effects of this class? Is that perfect? It's not perfect. You can see that these are the 4 major entities in the market. The first is RAL. The first drug, RAL, has a problem of rhabdomyolysis and also the allergy. For DTG, you can see that the DTG is now highlighted as the first line, preferred first line. However, it may also have a problem of a rash and nausea and the increase of creatine and the body weight gain. And EVG, you can see that this drug may also have a GI reaction and the increase and the decrease of EGFR, and it also have the neural disorder, mental disorder, and headache. So the blue the blue complications refer to those adverse reactions higher than 10%, and the red ones actually are the severe ones. And also you can see that the big may also have a problem of EGFR and also the body weight gain. So these are the big four in the INSTI class. When we talk about the ART treatment, any drug will have side effects. This is something which is inevitable. And also there are some toxic side effects of accumulate. That is, there is a time lag between the development of a drug and the identification of the side effects. So some of the side effects will accumulate in the during the treatment. We have to keep an eye on the side effects. So for the time constraint, I have to finish 40 slides in 15 minutes. So it is a big job for the interpreters. It's a big job for the interpreters to interpret such a quick, such a rapid, fast presentation. So you can see that there are 5 major problems. You can see that the NRTIs actually are metabolized by liver. So there may be a liver toxicity. And also you can see PI and NNRTI and INSTI are metabolized by the liver. So liver problem may occur. Another class is renal disorder. You can see that for PIs and for NRTIs, they are metabolized by the kidney. So kidney stone, for example, may happen. And also some of the drugs like NRTIs and the PI or INSTI may have cardiovascular and metabolic side effects. And NRTI and INSTI may have toxic side effects related to CNS. So have a look at the liver damage. This is the incidence of liver impairment. So the incidence, so you can see that the incidence of liver impairment is higher than 10%, 10% to 30%. And also this kind of a DAD study indicated that the combination of efavirenz plus TDF and the FTC, you can see that it has a very high it has a very high incidence of liver toxicity. Compared with the regimens that's not containing EVF, you can see that the efavirenz will have a higher incidence of liver toxicity, and you can see that the INIs may also show that the INSTI are also metabolized by the liver, but it may also have a potential effect. ABC should be metabolized for the patients with a liver impairment because ABC is mainly metabolized by the liver. However, for other drugs, you don't need to adjust the dosage if the patient has a liver impairment. So the second class is renal side effects. So I emphasize that NRTIs and the PIs are metabolized by kidney, and also INSTI will inhibit the secretion of creatine by the tube. So that's why there is some effect on the kidney. So you can see that for NNRTIs, it may also have some kidney toxicity, which may be neglected by us. So we have to put an eye on the potential side effects. And in the TDF, you can see that the incidence of renal disorder is very low. However, in the reality, in the real life, the incidence of renal impairment of a TDF is 3-fold higher than the clinical trial. So that's why you can see that in the real world, the problem of our kidney is much worse than the clinical trial. We have to mind that. For the patient with renal disorder or with some renal complication, what are we going to do? So this is the guideline in 2014 and in 2017. So for patients with EGFR lower than 60 or with some proteinuria, we need to stop TDF, and also we should stop NSAID. We should stop NSAID. And actually, it's difficult to manage the ward because once the patient has a fever, we may use ibuprofen or other NSAIDs. Those kind of NSAIDs will increase the toxicity on the liver. So this is the 2020 Europe guideline. This is a very good guideline. So you can see that this is this is the judgment of renal disorder based on eGFR, and also the ratio between creatine and the proteinuria. This is a very important. Now you can see that we will use the ratio between the albumin versus eGFR. So you can see that even though the eGFR is higher than the 30, if the ratio between the albumin and creatine is not good, the renal function is already very poor. So you have to mind that even though the eGFR is higher than 30, so you can see that these two indicators or parameters are very important. One is the eGFR, another is the ratio between albumin and the creatine. So those kind of new parameters are very sensitive for us to identify patients with a potential renal disorder. And this is the recommendation. If the albumin creatine ratio is not good, for example, the ratio is between 15 to 50, you need to consider replacing TDF with TAF. And you can see that in this case, you should avoid the TDF in those kind of cases, because TDF should not be combined with some PI, because a PI will increase the concentration of TDF. So that's why PI should not be used together with TDF. If the urine protein creatine ratio is more than 50, and also you can see that if the eGFR is less than 60, or if the patient has the history of a kidney infection, you have to avoid the TDF in the regimen if the patient has those kind of problems. And for the dose adjustment of ART, you can see that only one drug need to be adjusted for the patient with renal disorder, and the rest of the drugs will not be adjusted against the renal impairment condition, because those drugs are not metabolized by the kidney. Only one NRTI is going to be adjusted. And how about the aged care and also the cardiovascular health? So for the new diagnosed patients, we need to screen the cardiovascular health, for example, the lipid and blood glucose testing to evaluate the risk in the next 10 years. And also you can see that this is the prevention, for example, stop smoking. The patient should quit smoking. This is something they must do. If the patient has hypertension, the blood pressure should be controlled at around 130/50. If the patient has the coagulopathy, you need to use some aspirin to prevent. One patient yesterday had the myocardial infarction, and we didn't have any time to run PCI, so we had to do thrombolysis beside the bed. So that's why you have to mind the coagulopathy or the the tendency of thrombosis, and the HbA1c should be lower than 6.5, and for the lipid, you can see that the LDL-C must be lower than 1.4. So if the patient already has some cardiovascular events, and you still need to continue with statin, and you have to be more stringent. You have to be more stringent with some LDL-C.
Here are other high-risk factors. For example, a recent events of cardiovascular events, or family history of cardiovascular events, or family history of ischemic stroke, and also potential atherosclerosis. He also demonstrated the impact on the lipid and glucose profile. This is a common risk to NRT, NRTI, PIs, etc. The previous table was one that I developed, and the statin has been used oftenly, and those are recommended. However, for the agents mentioned later, I'd like you to avoid. Here shows the medications that you need to avoid when patients have higher risk for cardiovascular events. The third part is central nervous toxicity. This is a severe condition. For example, EVF, you expect 40% of risk. Sometimes it is very severe, such as personality disorder. Recently, I finished a trial and we found more than 58% incidence of sleep disorder among these patients. However, they should be compliant to the regimen for the rest of their life. Therefore, we need to think of the necessity of some agents, for example, anxiolytics. And here are studies from 2012 for it mentioned that among 20% of risk from EFV, here are the risks across the board, except for the NRTIs. The other agents comes with central nerve damage. So the same is true demonstrated in this study, though there is lower incidence. For example, lower than 5% of neural-related complications. Therefore, we need to recommend the screening for psychological and neural function. This has been recommended by many guidelines. However, when we find significant findings, what should we do? Then we may learn from Ditan Hospital in Beijing to streamline and categorize the proper treatment. For example, we need to screen patients for pre-existing risk. If the patient has those risks, then you should avoid EFV. But in certain resource-limited scenario, patients are left with no other option other than EVF. Another category of toxicities are for the skeletal muscular system, in particular osteoporosis. So there are controllable risks and non-controllable risks. You can't modify age and race, but there are factors that you can moderate. For example, weights, you need to increase the weight to a certain level. You need to stop smoking. You need to increase the intake of good protein, good and quality protein. Here shows the incidence of osteoporosis with the red and of osteoporosis, and on the right-hand side, that is China data. Also, osteoporosis has been found quite prevalent among our patients, and these risks are inter-associated. Different agents may have different level of impact on the bone marrow density. This guideline also talk about the risk factor according to different age groups. Then you need to scan the patient with DEXA. And it should be age-based. For example, when they are above 50 years old, and then you use different parameters for the elderly versus the younger population. All the guidelines mention that you need to avoid TDF, and you can choose TAF. If osteoporosis already exists, then you need to transition to a TDF-free regimen. There are other things that we can do. For example, change of lifestyle, increase intake of calcium and vitamin D, and the use of hyaluronic acid or zoledronic acid. There are studies indicating increase of bone marrow density. However, I don't have experience on the use of zoledronic acid in our service. And we need to pay attention to these chronic conditions. We know that these agents are effective for those conditions, and we need to transition the patients to a regimen that is safe and sustainable because the patient should be on the ART for the rest of their lives. And we need to tailor the regimen to the patient's needs. We are expecting good results from ART. However, they always come with adverse reactions. Therefore, we need to monitor various function of various organs and systems. Thank you. Thank you, Professor Zhao. I also followed the on-site simultaneous interpreting because Dr. Zhao provided a very intensive talk. I'd like to spend some time to thank the translators in the booth. It is difficult for me to speak and follow her, even in Chinese. Now we are moving on to a panel discussion, and please come to stage. And we need to manage time better because we will expect torrential rain in Beijing, and we hope that you can go home safe. So please come to the stage. Please prepare your questions. And we have only 20 minutes for this discussion. Professor Shen, you are from Youan Hospital. Over the past 10 years, for HBV and syphilis and HIV, I know you are working on a program to eradicate the 3 infections in the mother-to-child infection. So would you like to brief us on the updates? I know that we've reached the target for HBV, and for syphilis, we've reached 100%, and also HIV, 100% of blockade of the transmission. Even for syphilis, actually it is easier because all that we need is penicillin. However, I like to remind you that you should keep trying the patient on the possibility of penicillin when they show positive results during the first skin test. So after a certain period, you need to try on the patient again. There are cases when the patient turned out negative on the skin test for penicillin after the 8th trial, and when you are able to provide penicillin, the likelihood of syphilis control is higher. This reminds me of a study earlier that there is 1 infant born with syphilis every 6 minutes. I know that paper that was from Nanjing, East China. Currently, about 90 or 80% of syphilis patients are latent infections. According to the US guidelines, the pregnant women do not need to receive treatment, and they can still give birth to healthy babies. However, in patients, we have seen various changes in the guideline, and all in all, they need to stay with 2 courses of treatment for syphilis. Then you remind me of another issue that it takes 3 mainstays for resources support. This reminds me of the update of US guideline, the WHO guideline, because it is a guideline more tailored to resource-limited settings and regions. So currently in China, can you talk about the proportion of patients receiving the medicine from the free of charge program of the country, or how many of them would rather spend money on the more expensive drugs? Can you brief us on the trend? I feel this is a difficult question that I can't avoid. Indeed, it's around 19% of patients receiving medication from the national free program. And we are seeing more and more patients who spend money on the patients that are out of the government reimbursable agents. That means only some of the patients who are entitled to the government insurance would receive the drug through that mechanism, right? Yes, indeed. So among the populations entitled to the government reimbursement scheme, then only half of them would receive the medicine from that mechanism. Well, a follow-up question would be that, as I mentioned, there has been optimal regimen and suboptimal regimen, and there should be transition from a suboptimal one to an optimal one. Those are the wordings from WHO guidelines. Also, there has been strong recommendation from WHO and the US guideline in transitioning the patients on suboptimal regimen to the optimal one. What's your take on this? We are recommending the same thing, but it depends on patients' financial status. It involves affordability. In particular, with the impact of COVID-19 pandemic, we have seen patients who have more difficulty financially. So we hope to realize such transition, but it also depends on the financial status of patients. So Dr. Zhao, WHO and the US guideline also recommend transition to optimal regimen. And in your talk, within a short time, you ran through the data and I felt it's quite difficult to understand the Chinese or for the translators to turn it into English. You talk about patient-centered care and help them achieve an acceptable quality of life. So what's your take on the transition issue?
So what is the optimal drug? I have to emphasize the importance of surveillance and testing. This is highly important. No matter how good the drug is, anyway, it will have toxicity. So patient will ask for the best drug. The suitable drug is the best. So this is the second point. The third point, we don't touch a lot about the guideline. Professor Zhang just showed us the WHO guideline. According to the American guideline, back in 2018, due to the toxicity of TDF, TDF is, driven out of the preferred regimen. However, in the 2021 guideline, TDF was put back into the guideline. Why? Before the initiation of the treatment, there is a high incidence of osteopenia. Some patient will have osteopenia, some patient will have normal bone quality. So if the patient bone quality is good, we can still use TDF. Another problem of efavirenz, you can see that why the efavirenz and 3TC was put back into the guideline. It has a pretty good profile on weight gain and lipid. However, we have the problem of efavirenz, the neurotoxicity. You can see that when we talk to Janice Monia, she talked a lot about mental disease. I don't want to talk about mental disease. We can't deal with the mental disease, and we can't solve that. You can see that the mental disease is a kind of a subjective condition, and it is difficult to handle the subjective condition. If the life and the work is not impaired, the patient may still use some efavirenz. You can see that I think that we, as the infectionist, we should start to pay attention to the mental health of the patient. Chinese patient can, undertake a lot of things, but we have to mind that in the future, if those kind of new drugs will be put into the reimbursement or put into the basket of free treatment, a lot of our patients will be happy to take that. When we talk about money to the patient, when we talk about the self-paid drug to the patient, they will consider a lot of things. For example, their expectation will be elevated. They would expect that the new drugs will have no toxicity at all. So this is another relation with some the new drugs. I think that WHO should invest something, in the guideline of WHO. They provide the solution to the whole world. However, those kind of guidelines will not be responsible for the payment in the third world countries. I think that if in the future, if we can have a better price of the new drugs, patients will be more comfortable in taking those kind of drugs. Professor Zhang is the leader. He opened the door, of China to embrace the HIV treatment. He introduced the HIV treatment into China. My question to Professor Zhang is, what's your expectation for functional care or a functional cure, or is a functional cure something not achievable? So this is my question. When we talk about a cure, you can see we as the physicians, our ultimate goal will be the cure of HIV/AIDS. However, it's a very difficult job. So what we can pursue is the functional cure. For example, London patient or Mississippi kid, you can see these are the examples of having functional cure. I think that my understanding on functional cure is to stop the medication. However, virus is not totally eradicated. There is, there is still a load of virus in the body, but it will not make trouble, and we can stop the medication. So this is the situation of a functional cure. We talked to the expert of North Carolina. He said that he will not see the functional cure in his life. So he said that HCV is curable. This is the milestone, the drug of Gilead will cure totally HCV. So this is the only example. But my response is that if the virus infected the human body, and if we can't totally eradicate that, can we still cure the condition? For example, like HBV, in the future, we have, the expectation of functional cure. 90% of the HBV infection will be self-cured. However, it's not true for HIV. So I think that for HIV, functional cure is something very far away. And also, there is a pathway for drug development from phase 1, phase 2, and phase 3. So I think that functional cure is not something realistic in the next 5 years, but we should not lose the confidence. Why we frequently update the guideline? Because we have the new drugs. When we talk about the new drugs, the very important criteria is toxic evaluation, for example, bone toxicity and renal toxicity. According to the new guideline of WHO, if the patient has a renal impairment who is not tolerable to TDF, we can start with a TAF. So I think that the management of toxicity is something achievable because we have the multiple choices. You can always choose something which is suitable to the patient profile. But functional cure is still something far away.
What are the major barriers to expansion of scale of prevention and treatment of and care for the people living with HIV in China?
这 major 问题的话呢，我觉得还是第一个的话，今天上午就韩主任他们都做了很多的报告，就是首先
In this morning, Professor Han and other speakers did a lot of presentations. Firstly, I'd like to say that my personal impression is that Chinese government pays great attention to HIV prevention and treatment because we have the 5-year planning for HIV/AIDS in China. So we have we are now in the 14th 5-year planning for HIV/AIDS prevention and treatment in China. And also we have another 5 years planning to stop the transmission of HIV/AIDS. So this shows the attitude of our Chinese government and also the investment into HIV/AIDS prevention and treatment is always rising year by year. So that's why I asked Professor Sun this question. In the UN, in the WHO, according to their research, even though the viral load is controlled and the immune is reconstructed, we still need to consider, converting the patient to the optimal treatment. I think that the major barrier is to identify the patients. This is the major barrier. So for the key population, if they have the awareness to have a self-testing and have early diagnosis, this will be good. And once diagnosis is established, there are some problems of treatment. For example, we have 3 payment schemes: self-pay, free drug, and reimbursed drug. And how to achieve 90% for 90%, how to achieve the last one, which is 90% of the HIV carriers will have good life quality. You know, back in the history, it was very difficult, to identify a case from the rural area, but that's not the true, that's not the same situation in China now. And I also want to stress that the testing capability is not as high as what we expected. So you can see the timeliness, and also the drug resistance testing. Those kind of testing resource is still pretty limited in some areas of China. In 2019, the drug resistance ratio in Ditan Hospital was 3.0 something percent in the Ditan Hospital. But in 2020, all of a sudden, we found that the drug resistance rate was 7% something. So if we consider the potential drug resistance patients, the percentage will be even higher. So drug resistance is something we should tackle. HIV/AIDS is the common enemy for all the stakeholders in the world. We have to mobilize all the resources in the world to create a synergy, and then we can conquer this problem. And in this morning, Professor Han also said that when we talk about donation, when we talk about the financing, I think that we should try to reduce infection and to further improve the life quality of those people living with HIV/AIDS. Okay, this is all I'd like to address. And how about the other professors? I totally agree with Professor Zhang. I agree with some of the major barriers. I think that drug resistance is a key barrier. We have a lot of drug resistance testing study, but drug resistance, the prevalence of drug resistance is still underestimated. One patient told me that I had 100% compliance, and I did not have, I did not have any pre-treatment drug resistance. However, I had drug resistance, and my viral load now is 300,000. So I think that if you don't have a surveillance, if you don't have surveillance, those kind of strains, viral strains with mutation will recover. So it's a kind of a wild phenotype. And if you put pressure on the virus, and sooner or later, those kind of mutated strains will be further selected, and then the patient will have a drug resistance phenotype. So this is something we have to focus on, the surveillance of the patient regarding drug resistance test status.
I agree with Professor Zhao, and I'd like to share 2 more comments as well. The WHO also mentioned the drug resistance report, and it is a concern. There are good news from Chinese government and CDC that starting from this year or next year, China will do more work in testing of resistance with increased governmental resources, so that we can have a better picture of drug resistance in China. And let's conclude the panel discussion, and we can't overuse our opportunity. I need to call it a session. Thank you very much.
好，按照我们把那个画面能切到那个安透